prepared one question that I would like each of the speakers to kick off on. Things that we encounter that interest me, and I invite all of you to think also about the question, to pitch in, and maybe to ask your own other questions at the end. So I would like to start with Erik. This has to do with also things that Carl talked about. When you fit a model, you almost guarantee to see that because of all the choices you make to optimize things, that it works better on the data on which you have fitted it than on new data. So any significance you see there is exaggerated. And in our experience in consulting, a lot of that already picking and choosing, selecting even the question they come and bring, is in fact happening behind closed doors at the investigator site before they come to us with the question. So we think we have a fresh association to analyze, but in fact it often is not the case. And I just wonder, from Erik's experience, whether they also have seen that happen, whether he thinks it's a big problem, and what might be solutions to help prevent this, because I'm sure myself that it's quite detrimental to the process.
Well, thank you to the question. I might say absolutely certain that this proportion is something between 0 and 1. I'm sorry, I really don't know. What I sure is that researchers, all of them, had a great pressure to get results published. And some of them don't truly understand statistics and don't truly understand the repercussion of badly reported results. So I think this is a very dangerous combination. And I would like to say that we, researchers, are responsible for this because research is parasitizing the work of clinicians or the work of teachers. John Ioannidis, just half an hour ago, stated that the evolution of our researchers goes from to be just a student to become a full professor at the end of the process. Why? Why? Teaching is completely different to do research. Why do we assume that a good researcher is a good teacher? And exactly the same is happening in the clinical setting. Why we assume that the best researchers have to be in the best places for doing clinical work. So my point is that we are awarding the doctors not for being doctors, but for being researchers, and also the teachers. And I think that the problem here is that we don't have an alternative measurement such as impact factor for doctors of teachers. That's my view, sorry.
Okay, so mostly the rewarding system, you think, is encouraging this?
Yes, definitely.
Any other views around the table here on that?
And a few on exactly what? A few on what, additionally to this?
No, I'm just asking whether you want to add anything. No. Anyone in the audience? Any thoughts? Yes, please.
Oh, hello. I'm Aurélie Nevel from CNRS. So I want to follow up on what Erik just said. And so earlier I also wanted to thank Professor Moons for what he said in his talk, that actually to do the kind of work that is involved for meta-research, you need to bring together specialists from a lot of different areas, so including statisticians, clinicians, epidemiologists, in the case of research that I was involved in, also natural language processing. And I think it's we cannot have expertise on all these different fields. And in my experience, it's difficult first to find the right context to bring all these expertise together, and also to facilitate the exchange of expertise, and to not become ourselves experts of other fields, but to understand enough about the other field that we can see what our contribution can be to one another. And so I'd like to ask the panel members how they think that we can foster this kind of collaboration and, well, help each other across disciplines.
Okay, thank you.
Now, as you might guess, I couldn't agree more. That was also my final slides, that I think we should definitely stop bashing each other. And although this territorial drift seems to be very human behavior, so I have an understanding why we are doing that, and we are probably in the beginning of an era where first people try to convince each other that their own approaches are better, or at least as good. And I think that's the situation we are now in, to go slowly through to the situation where you are focusing on, that we definitely need to work together. And what I said, I think we have a lot of lessons learned in intervention research and diagnostic test research, and also where I was focusing on in prediction model research. And we are just at the beginning of working together there with different disciplines, indeed.
So to pick up on both that and Erik's point, where I am, Imperial School of Public Health, it's highly interdisciplinary. Whatever we're doing, you've got different people working alongside, you've got people with multiple skills. And so it tends to happen relatively naturally. If a young person goes in, they will pick those up. Now, maybe we should be doing it more formally, but it happens fairly naturally. I think what I'm more challenged by is almost, I think the people Erik was talking about was people who are not necessarily in centres of excellence, because you don't want a world where there are centres of excellence where everything's wonderful, and then the rest of the world which is completely disconnected. And if I understood correctly, you were talking about almost the problem of training of doctors, where we want them to be research savvy, but that tends to get translated into you must do your own little bit of research. Whereas actually what we want is people who understand research, know how it fits into the system, that if they're called upon to be somebody on some guidelines committee would know how it's there. And that, I think, is the dilemma. I mean, I suspect some universities are now doing more on that grounds, but I think that to me is the real tension. And how does somebody in that situation learn about other areas? I mean, there's much more online stuff available now, and maybe we should be making better use of that. Or maybe everybody needs to spend some time in a sort of in a rich environment, even if they then go back to sort of somewhere that's either more remote or more specialised. But it's a real challenge.
Yes, of course. Thank you.
Do you have any thoughts on training in that regard? Clinicians, what should I learn from methods and statisticians?
I mean, their training is much more integrated than it used to be, at least in the UK. So when I first taught, they did their anatomy and their biochemistry, and they had their statistics course in their first year, and then epidemiology at some other part, and then they did their clinical, and they were somehow meant to magically integrate it. We've gone over to problem-based learning and then sort of successes of it. Now, whether they then see that there even are these separate disciplines, whether they understand the rigour, I'm not sure. I think it's done better in some than others. And actually, it's almost harder to influence the curriculum there, because it means that you've really got to get stuck in. But I think that's part of the answer of people here. If you're asked to do some teaching and later on get involved in education, take it seriously, go to those meetings, say, well, actually, if you're doing that, you could be looking at what's the pedigree of that research, because it's very easy for us to kind of hyphen off and just leave it the old ways. But again, no easy solutions.
All right, thank you. Yes, please.
Coming back to your question, Else, do you think that publishing, whether it be in institutional repositories or journal publications, protocols and statistical analysis plans would help or hinder the situation that you sometimes find yourself in. And to incentivize that, we need to give more credit for publishing of protocols and statistical analysis plans and not put it all on the report at the end.
Yes, well, thank you for that. I do think that publishing protocols would help, but for observational data, it's tricky because I think they would do what they sometimes do to me now. They first peek at the data, or these are data that have been building up in the practices for a long time. So they know, they have seen the data before, and so they would still do that and then come to a protocol that is, let's say, informed by the data, in fact, already. So that issue of selection is not altogether overcome. It's different when you go out to gather new data and you launch a protocol ahead of time. Then this data snooping won't happen. But for building up observational databases, I don't see how that in itself could prevent the selectivity of the question asked that's already based on what is manifest in the data.
Yeah, right. Maybe we cannot prevent what is already manifest or wrong in the data, but since we know that people are going to embark on that data anyhow and start analyzing that, again, I quote this morning lecturer, overnight, they do that in 10 seconds. I think that we have to continue by, even though the data was there before the protocol, maybe we should not call it a protocol anymore, but description of the data and where it comes from and what's in it actually when the data were documented also over time. Knowing which measurement was before which other measurement, it's also very helpful to know. Now that data is lacking, that information, is lacking, so we have to move forward and describing data sets, even though it was not a pre-designed study data set, but describing data sets is important, otherwise we have no clue what we are analyzing. It reminds me suddenly, and I think many people in the room have that situation encountered themselves, that somebody walks into your office years ago, 20 years ago, with a floppy disk. I think it was called a floppy disk with the data. And then they asked me, can you analyze the data? I'm sure that people, I see a lot of vertical nodding heads, that means a yes. We had that situation years ago. We don't know what to do then. We can do some analysis and we can link and make correlations, but are we answering a question if we have no clue what the data means or what it annotates? That I think is the current situation with big and diverse data sets. So we have to go to a situation where we go for descriptions of data. Whether we call it protocols, I'll leave that in the middle right now, but describing them is hugely important.
Thank you. I've read the fundamental thing of Paula's question slightly differently, which is that there are all of these tasks. How do we apportion credit for them? And then there's a substantive question of what should those tasks be in particular context. But, John talked about the film industry, directors. The other letter I did co-sign, because I thought it was a brilliant idea, was one Matt Side put together saying that actually maybe the right model is that we have the equivalent of the IMDb, which is what they have for people in the film industry. And you list, and if you've done the second analysis on a clinical trial, you say that that's what you did. And if you say that you wrote the analysis plan for a meta-analysis, that's what you did. And if you contributed 50 patients to the genetics database, that's what you did. When we come to look at promotions or hiring, then you say, well, in the world you did, is that the right kind of trajectory that you started off doing redoing the analysis as a check, and then later on you went on to developing the analysis plan, and then later on you went on to designing these big studies, and you see just as, second grip, first grip, and then, a cameraman or whatever, you would follow their trajectory. So I think that's the right way to do it. I think there's then a question in particular context of what those tasks should be, and the ones you need in a clinical trials world where you pre-specify ahead of time, which is the current paradigm, are different to what you might be doing in big data sets. But I think we then have to do some thinking about what that looks like. But I think Paula's if I understood the core part of it, it's how do you give credit to these multifaceted things? And I think the film database would be very easy in this day and age.
Erik, you want to...
Let me come back to the question. I found two very big difficulties trying to explain to doctors why the p-value is not what they think there is. The first one is that they didn't study conditional probability. This is completely easy. I see. Can I have the significance? Yes. Okay. I remember a paper from Stephenson on significance about invalid inversion. In that paper, he said that the probability for a Catholic to be the Pope is very low, but the probability for the Pope to be Catholic is higher. So if they really don't have the practice to calculate conditional probability, to understand those things for them is almost impossible. So should doctors be trained to be researchers? They have to understand conditional probability. Or should doctors be trained to be physicians? That's the point. For a physician, make a decision needs a threshold. To take the patient to the surgery room, they have to get some kind of good point to down the patient or not. But to have evidence is completely absurd to have this silly rule of higher or lower than p-values. So again, my point is that we have to think how to promote and select researchers and how to promote and select teachers and doctors, because maybe they really need to have an alternative to this horrible measure of the impact factor.
Okay, thank you. Maybe that can bring us to the next question, which I'd like to put to Deborah. Has to do with p-values, and I was wondering whether we could, while the p-values are still there and in tables with stars, whether we could impose to have, whenever you put a star there, also have a measure that does not, as Sander Greenland again really gets upset about, that completely emphasizes the null hypothesis at the detriment of the alternative. Could we not, with every star that sort of almost gives a strong sign of significance, hence the null is not true, also have the counterpart and an indication, a probability that that detection or discovery is in fact a false positive? It would require, of course, to think about what is the worthwhile alternative and also what is the prior. You'd almost have to be Bayesian. It would be a lot more work than to put a star there, because you have to think also from the other perspective. So what would you think about the combo?
Well, I think that's why I've got such a dislike of stars in tables, because it's a shorthand for something. And in some worlds, if you're in that world, you know what it is. If you're in a two-group clinical trial, it's the null hypothesis is, or might well be, that the two drugs are the same, and that the alternative is that they are different. And because everyone does two-sided, you know what they are. But even that's not straightforward. As soon as you've got multiple groups or even a factorial thing, it's really hard. So I don't want to use them at all. I think actually the more you put on the table, the more you clutter it up. And it makes it harder to actually read the numbers. But I think whenever you do use significance testing, if you're going to use it, then you should say what you're testing, what the alternatives were. So, if you're looking to see whether there's an interaction, especially if it's slightly post hoc, a significance test can be a useful guide. But you need to clearly say that this is to test whether this drug is working differently in this group to in this group within these subgroups. And that's fine. And you may need to talk about the alternative. So when you do use it, you should give that. But I don't know that doing it in the table, it sounds like an efficient thing to do, but you'd have so many footnotes.
Yeah, so maybe like the Bayesians used to do, to have this region of clinical equivalence and then of clinical
Yes.
benefit and harm, which that too requires some thinking.
It does, because again, a region of equivalence is a poor man's decision analysis, because you have to say why that. Now in bioequivalence, it's become almost de rigueur that it's 80 to 125% for most drugs, but actually if you read those guidelines, that you'll see for some of them, and that would include things like epilepsy, you do need much tighter control.
Yes, yeah.
But
that would have to be adapted to the question.
But there is implicitly a decision in there about where those guidelines are. I mean, some of us have just been involved in the Delta 2 guidelines about how you choose sample size in clinical trials, the same about equivalent. You actually need to do some thought, and there is a decision analysis buried in there, although most of the time we don't do that thinking and we use deltas as a shorthand. But
okay. I would imagine in the big data setting, where everything is significant, you have to think about what is equivalent versus not, what are meaningful effect sizes.
Yeah, indeed. I was just thinking about the p-value and prediction modeling. That was my topic. Let's first move a little bit at the current situation. So before the big data situation, actually, there the p-value is much less of a thing that we focus on. What I mean is, let's start with somebody has developed a model. The next step is, as I explained this morning, is to see how it validates, how well it predicts, and I'm using a few terms now, discriminates and calibrates. For these assessments, we don't use p-values. We simply give the C-index with the 95% confidence interval, we give the calibration plot, and we describe where it over or under predicts. There's no p-value there at place. Where the p-value is a thing in prediction modeling is during the development. Because there, if you have a lot of data and a lot of predictors, you have fishing expedition and you will see false positive predictors. But you know, the good modelers already use lasso methods, use penalization methods, use bootstrapping methods to penalize their p-values. Not enough usually, but at least I have the feeling that the p-value is less of seen as a problematic thing, because we always then in the end validate the model as a total and not only focusing on the predictors, the good modelers. Now going to the big data situation, yeah, of course, as John said, we get a lot of false positive predictors during the model development, and that's why, sorry for repeating my message, a model development, yes, p-values are usually used there, but it's just the very first step. The next step is how well the model as such validates or predicts, and there no p-value comes around in that inference. So it's a little different situation between the trial world and the prediction modeling world, I think, but arguably, of course.
I think that's a nice example where if you are using p-values, you've got to specify the whole context really carefully. It's not my world, but I understand that if you do some pre-selection, there are too many, let's choose the 20 most promising. Actually, anything that's then a p-value isn't properly conditioned on, it's another version of selection. And so they can be really misleading.
Definitely,
So,
agree.
Yeah, if you are going to use them, you have to use them, as David Spiegel said, lovely phrase, they are really delicate.
Yeah.
Used properly, they may be helpful.
Yeah.
But I agree, actually, if you then prospectively validate, then you're testing out the model for what it's meant to do in the context you wish to use it, thinking about practicalities of do we have cholesterol samples to hand, or is there good imaging? And it's a holistic decision. You can still formalise a lot of that.
I agree, but you don't need a p-value for that inferences.
The p-value is such a small part of it, but there are areas where it's actually downright dangerous because it's not what you think it means.
I agree.
Anyone in the audience? Yes, please, Patrick.
Yes, if I may, Didier Dreyfus. I'm purely a critical care physician and hardly a methodologist, but I am here to get treatment. I would just like comment on p-value from the point of view of a clinician. You know, I will deal with two studies on mortality in intensive care. The first one was the activated protein C for septic shock. It was so-called significant because it was P005. Did I use it? No. Why? First, because there were several drawbacks that did not reach significance, but there were bleedings. Second, it was highly expensive treatment. And it was secondarily demonstrated that it did not work. Second example, prone positioning during mechanical ventilation of patients with very severe acute respiratory distress syndrome. Highly significant value. So I did it. Would have I done it if it was only P05? The answer is yes, because it was no cost. Very simple. And physiologically sound because it increased PO2.
Yes, thank you for examples of smart use of that. Patrick, did you also have?
Yes, I have a question to the panel. So p-values and significance testing are not exactly the same, actually. So we go back to two different traditions. One is decision-making perspective, which is significance testing with Nyman Pearson tradition. And the other is the Fisher tradition, actually continuous p-value as a quantitative way of indicating support for a specific hypothesis. So wouldn't it be nice for the meta-research community to develop these two things further, actually, to apply more consistently a decision-making perspective on the one hand, actually where that's appropriate, for example, for trial, and using something of a multi-criteria approach. And second, actually, for the to develop more appropriate quantitative measures to express uncertainty or alternatively to express support for a specific hypothesis. You've alluded to it, but actually I think maybe this community can help. Actually, initiatives are ongoing actually to develop these two trends further. So to disentangle the heritage that we have, the very nice decision-making perspective, but now with alphas and betas set in stone. And on the other hand, actually, the Fisher tradition of expressing, of having a quantitative number that expresses support for a specific hypothesis and could be replaced by quantitative expressions of uncertainty.
I mean, I think I'd absolutely agree that finding ways to show uncertainty in appropriate circumstances is really important. And again, David Spiegelhalter is doing really nice work on official statistics, for example, when you put out projections, how can you shade to show that uncertainty? And I'm in two minds about whether it's helpful to go back to Pearson and Fisher or not. I mean, in some ways it's very helpful to think through what they were trying to do. Whether that's the right starting place for a new generation, I'm less convinced, but I think the important thing is thinking about either as a measure of support or, as you say, this sort of very fixed decision-making kind of approach, which, I mean, as I indicated, I would take a very different approach to decision-making. Maybe younger people in the room would have a view on whether they find that helpful or whether that's just so old hat it's, two centuries ago.
Okay, maybe this is a good time to move to the third question, which is primarily addressed to Carl and prediction modeling and the role of machine learning versus more traditional ways of thinking about statistics. I recently had the pleasure of seeing a talk by Brad Efron where he put the two next to one another, and it was his conviction that there have been really great successes with machine learning, but when it comes to transportability, which you alluded to in your talk a lot, to other situations, to future, then certainly for the middle range future, the more traditional model building prediction models appear to survive better. They're better adaptable to new situations because the real drivers somehow that matter seem to have been implemented better than in some of these black box, deep learning and other machine learning tools that do great on the current data set and even a little outside the current stream, but are a bit less robust or transportable to new situations. So I wonder whether you have experienced that, and also what it means in part for training. Because our traditional master in statistical data analysis has now two different tracks. One that's more computational and machine learning oriented, and one that's more traditional. And it's clear that certainly some of the machine learners come in thinking, we really don't want anything of that old-fashioned stuff. That's not for us. We are sort of trying to fight to give them at least the basis of that, because we think it matters. But I'd be very interested to hear your views on all this and experience.
So you force me now to oppose Brett Efron. Thanks for that. Yeah. I hear two things in the question. One is that short-term prediction, short-term outcomes and longer-term outcomes. And the other one is the fine-tuning of the machine learning models on an existing data set and whether it transports to another data set. Now let's start with the first. Indeed, short-term prediction is always easier than long-term prediction. So my own experience, I also did some neural networking and decision tree analysis, but all in diagnosis. And that means you're predicting actually the current situation. And that's usually, if not always, easier to predict than if you have to predict something over 5 years of time. And the reason for that is that during those 5 years, a lot of things happen in life and in data sets, and people undergo interventions, often based on the predictors, so therefore the outcome occurrence changes due to the interventions they receive based on the predictors you predict, so you get so-called misprediction. And the machine learning models have particularly if it's on big data, have a harder time to incorporate that all, because they simply focus on, if they let the computer completely loose, on the correlations that they can find. For example, the timing of the predictors is usually important. I have seen people building a machine learning model where they actually use predictors to predict an outcome where the predictor was documented after the outcome. Now we're laughing, but the data set, if the data set doesn't tell you that, you don't know. So people are still needed to, here we go again, describe the data set that you're analyzing. Now, the transportability of machine learning models to other data sets, yeah. But again, there are also, before I give an answer, there are many machine learning people and data scientists that know what they're doing and really think, and not only pressing a button and let a black box coming out of it. But if you do that, if you simply press a button, yeah, that's the essence of machine learning techniques. It fits the data as good as it can. That's the essence of statistical modeling. That's actually also the essence if you let a logistic regression simply do an automatic or backwards stepwise selection. It fits the data as good as it gets. And then, of course, the machine learning modeling overstress that even, so of course they have a poorer generalizability to other situations. And I also think, I agree with Brett Efron, I'm sure I agree with Brett Efron, by the way, is that yes, the transportability of models where human beings have looked at the models, understood the models, and perhaps also fine-tuned the models based on experience and knowledge, leads usually to better generalizability of those models. I agree on that.
Okay.
Very much.
Anyone other opinions?
Yes, I mean, I think it's a very nice described example of a very good general rule, which is to know the purpose of what you're doing an analysis for. So actually, if something was recorded a bit later, but it was actually, it's just the data's late coming in, perhaps the blood samples took a while to analyse. If it's for descriptive purposes and to understand what's going on, that may not be a problem. If you're proposing it for use in clinical circumstances, you have to work with what's going to be available. And if you don't make that distinction, it's a problem. Now, I gather a lot of machine learning is very much about sort of prediction and not too worried about what's going on, whereas the transportability says, actually, we do understand. But I think that's a really important fundamental distinction. But for any analysis, you have to think, why am I doing it and how is it going to be used? Because if you get that wrong, you're going to make some really stupid mistakes If you think that through fairly clearly and transparently, that's where writing it down and protocols come in, then it's clear why you made the decisions you did, why you used the guidelines you did. And at least if someone else is then trying to replicate it later on, they know what your thinking was.
Yeah.
So.
There's a very nice example I got across by email from Frank Harrell, a guru in traditional prediction modeling. And he showed me a paper where people predicted the diagnosis of heart failure. And there were very sick people, and they actually got the diagnosis with a portable echo, the ultrasound of the heart. And there were people that were less sick, were actually being able to be moved to the ultrasound room. So the more sick got the portable echo. And there was a machine learning model, developed on a diagnostic model on that data set. And you know what the most important predictor was to diagnose heart failure? Having a portable echo. So that's a nice example. If you have no clue, because data is flat, and if it doesn't describe what's in it, you will get very strange models. And I can tell you, by the way, that model has a poor generalizability to other data sets.
Okay, my look at the clock says it's 1 o'clock, and since we're all in harmony, everybody's nodding yes, yes. I think it's a perfect time to stop and have the rest go on over lunch. Thank you very much, my panel and people in the audience, for your contribution.